like to welcome Dr. Sandy Schwartz. Dr. Schwartz is the Leon Hess Professor in Internal Medicine at the University of Pennsylvania School of Medicine, as well as Professor of Healthcare Management and Professor of Economics at the University of Pennsylvania's Wharton School of Business. He is an internationally respected leader in clinically oriented health services, research, and policy. Dr. Schwartz is a distinguished member of a number of panels and the national advisory committees. Among many other positions, he was a presidential appointee to the U.S. Preventive Services Task Force. Today he speaks to us about why patient-centered outcomes matter. Dr. Schwartz.
Now, I'm a lifelong Mac user. I'm PC challenged, so hopefully I'll be able to figure out how I advance these slides, and I've already screwed it up. So, yeah, I gotta end that. Yeah, that's it. Just those? Okay. Hi. So, I apologize for some of these slides. They were reformatted on the Christiana slides, and they may not all have formatted correctly, it looks like. But we've been talking today a lot about chronic kidney disease. And if you look at the title of the meeting, it's Partners in Research Developing a Patient-Centered Research Agenda for Chronic Kidney Disease. So Claudine asked me to spend a few minutes talking about what patient-centered research is and why it's important and what the implications of it are. And this doesn't project well, but if you look up here, about 15, 20 years ago, until about 10, 15 years ago, when the medical profession wanted to figure out whether something was worth doing or not, we would ask ourselves two questions. What's the safety? Are the side effects acceptable? And what's the efficacy? How does it work? Can it work? When you have ideal circumstances, you take carefully specified patients under carefully specified conditions, and you use the intervention with a bunch of experts who are paying a lot of attention to what they're doing, will it work? And that's really efficacy. How well does something work under ideal conditions? But that's like the tip of the iceberg. That's necessary but not sufficient. And it tells us whether something might work, but it doesn't tell us how it works. And so over the last decade or so, there's been a transition from the evaluation of medical care from safety and efficacy to effectiveness. Does it work? How does it work in the real world? And more recently into comparative effectiveness. Since we live in a world, fortunately in medicine, where we have multiple, often alternatives to manage a problem, what is the best treatment and how does that treatment vary? What are the best treatments for different people under different conditions? And this is what sort of leads us toward patient-centeredness, because this looks pretty straightforward. Okay, you assess safety, efficacy, effectiveness, comparative effectiveness. But things are much more complicated than that. One of my favorite stories has to do with Pope when he was in the States recently. He spent some time, as you know, up the road in Philadelphia. And from there he went to New York. And when he was giving Mass in New York, he got a telegram, not a telegram, but it's a text message that said, "You are needed right back at the Vatican. We have an emergency." So he hustled off the altar, ran out of the stadium, ran to his car, and said, "I need to go to the airport." But he was in such a rush, he went to the wrong car. And the driver in it was so overwhelmed to have the Pope in his car that he froze. So the Pope gently took him by the hand, put him in the passenger seat, and drove himself to the airport. Well, if you've ever been in Italy, you know they don't really follow the traffic rules all that strictly. And speed is considered discretionary, speed limits. So the Pope was driving like he was used to back home in Vatican City, and he got pulled over by a Jersey trooper. And the guy looks at him, and there he is, dressed up like the Pope with the Pope hat on. And he said, this can't be. He said, "Let me see some ID." And the guy gives him a driver's license, says, "The Pope, Vatican City." So he says, "I got to call this in." And he goes to his car, and he said, "Look, I've just stopped the most important person I've ever met. Do I give him a ticket for speeding?" And he said, "You stopped Chris Christie?" And he says, "No, more important than the governor." He said, "You stopped Barack Obama?" And he said, "No, more important than Barack Obama." And they said, "Who's more important than the President of the United States?" And he said, "I have no idea, but he's got the Pope for a driver." So So how we look at things may vary depending on where we sit. I had a colleague, a family medicine colleague in East Lansing, Michigan, a number of years ago, Jack, and I can't remember his name, last name. I have only known him for 45 years, but as you get older, they say the 3 things that go wrong. You get tired more easily, your sex drive decreases, but I can't remember the third. But Jack did an interesting story with chronic. He had patients with chronic kidney disease, and back then, transplant was relatively new and relatively hazardous. They had home dialysis, center dialysis. And he asked physicians, nurses, and patients what they would prefer. And the physicians all thought about home dialysis. And the patients reacted in terror because when you had home dialysis, there are coils, and one's going to always break, and there's blood spurting all over the thing, and it's not going to kill the patient if you know what to do. But families do not like that. That is not their idea of relaxing. The nurses liked center dialysis because they could interact more with the patients. And the patients at that time preferred transplant, even though transplant was very dangerous at the time. When it worked fine, but there were a lot of rejection, and everybody knows sometimes the sickest patients are those who have undergone organ transplant and are having problems maintaining the organ. And that drives home the view that different people who know the same types of things may have different perspectives based on how they have to interact with that treatment. And that really gets to the fundamental basis and premise of patients' outcomes, patient-centered research. So, again, I apologize. Maybe we'll just go without slides here, except that I don't remember what I'm going to say next unless I look at the slide. But what this slide shows is that mortality and morbidity are what the medical profession usually focuses on. How will the person survive? How long will they survive? And what are the major complications or sequelae of disease that we see? But when we talk to patients, we find out very different things. Patients, more so than doctors, more so than nurses, much more so than doctors, because nurses are better than this than physicians are. Patients are concerned with functional status, quality of life. How do we feel? Can we think clearly? Are we depressed or anxious? Do we have the energy to engage in activities of daily living? Can we be good spouses, good parents, good members of the community? Do we have sexual function? Do we sleep well at night? Those are the things that are most important. When Jack went back and talked to patients and he asked them why they were so up on kidney transplant, even though the results were nowhere near what they are today, they said, look, if I have dialysis, I'm tired all the time, I spend 3 days a week away from the family, blah, 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 blah. Said, if I have a transplant that works, I can go out and I can toss a ball with my son, I can take my daughter to the baseball game, I can engage more as a member of the community. So different perspectives, what we're talking about when we're talking about patient-centered is really fundamentally changing the locus and the framing of how we look at things from a medical perspective solely to really more of a patient perspective, where those of us who are healthcare providers are there to help the patient achieve what they want to achieve if they had the technical skill and knowledge that we had. So basically, patient-centered outcomes research or patient-centered research, the goal is to help people, patients, and their caregivers and their families, what Tabassum just referred to as the patient circle, make informed healthcare decisions and improve healthcare delivery and outcomes by producing and promoting high-integrity, evidence-based medicine, and this is the key part, that comes from research guided by patients, caregivers, and the broader healthcare community. So a lot of us in medicine, I've been doing clinical research my whole life for the last, 35 years at Penn, and we're really experts in study design, framing questions in a way they can be answered, analyzing them, and interpreting them. But it comes down to what questions do you ask? How do you ask those questions, and what information is going to come out? And one of the things we've learned, and why we've ended up with patient-centered care and outcomes research, is because we realize the questions we're asking sometimes are true, but not of value to people. Another one of my favorite stories is about a man who's in the gondola of a hot air balloon going over the Delaware countryside. Balloon's forced down. He lands in the middle of an empty field. He has no idea where he is. So he sees a woman walking by. He says, "Excuse me, ma'am, can you tell me where I am?" And she says, yes, you're standing in the gondola of a hot air balloon in the middle of an empty field. And he said, well, you must be a physician or nurse who does healthcare research. And she said, yes, how do you know? And he said, well, the information you gave me is precise and accurate, but of totally no value to me. She then said, you must be from the government. And he said, how do you know that? And he says, you don't know where you are, you don't know where you're going, but you're blaming someone else. So, anyhow. So the goal of, what makes patient-centered research differently is it asks questions that matter to patients and caregivers as well as to clinicians and policymakers. It doesn't substitute for clinicians and policymakers, but it makes sure the questions are the ones that among those questions are the questions the ones patient needs asked. It compares benefits, harms of alternative options that matter to patients, their family, and the community. There's a lot we do in medicine. We get frustrated when the patients don't adhere with our recommendations. But we don't often think about how realistic are those things. What is the burden we're putting on the patient or their caregiver? Is this financially feasible for them? Can they do this? Does it make them feel better or does it make them feel worse? And if we don't take those things into account, we end up in a situation where we have precise and accurate information that's not of value to anybody. I remember once when I was starting out on the faculty, and I had this wonderful woman the older woman who lived in West Philadelphia, who had congestive heart failure, and she would always come back in the hospital because she didn't take her medicine, and I could never find out why. And one day I must have asked the question differently because she said, Sandy, well, the reason I come in is I don't take my diuretics. And I said, why not? And she said, well, I live in a bad neighborhood in West Philadelphia, and my only way, it's too dangerous to go out. This is a long time ago. And it's not like that anymore. And she said, the only place I go out is go to church. And the van comes and picks me up. And and you said I should take my medicine every morning, and if I take my water pill in the morning, I can't stay on the van because I have to go to the bathroom before I get there. So I said, well, thinking what an idiot I am, take it when you get home. But she said, but you said always take it in the morning. And I said, well, I said that because that's when I take my medicine, But, that's a patient-centered piece of information. Patient-centered research considers the full range of relevant outcomes. It's conducted in the real world. Instead of being conducted at the hospital of the University of Pennsylvania, which we fondly refer to as the hospital of unlimited prestige, and everybody else in the region refers to as a hospital of unwarranted prestige, it's different. We see different patients, and the systems we have to care for them, and sometimes are different. When you get into the community, it's a different set of resources and environments, and really we want to know not what happens at Penn or Hopkins all the time. We want to know what happens in the real world where you have excellent doctors and you have good patients, but they're operating in a slightly different environment. And we want to know about subgroups. We want to know not only what happens overall, but where individuals, and if you're older or you're younger, or if you're a man or if you're a woman, or if you have a comorbid condition, a coexisting condition like cardiovascular disease or diabetes, what are the outcomes for you as opposed to what they are for other people who have the same problem? And then the last thing is communicating these things effectively to patients and communities. So what are the types of questions outcomes for patient-centered outcomes want to ask? Given me, my personal characteristics, conditions, preferences, what should I expect will happen to me? What are my options? What are the potential benefits and harms? What can I do to improve these things that are most important to me? And how can the people who care for me work with me to help me make the best decisions about my health and my health care? These are different. Most of the research I've done, I've had, a dozen articles in the New England Journal and maybe 15 or 20 in JAMA and God knows how many in internal medicine, and most of them have not been able to, they may have been good research, but you couldn't answer these questions. A patient or a physician could not have answered these questions after reading those results. So what can we do to make patient-centered outcomes research more useful? One, we need questions that inform clinical decisions. The questions have to be framed in a way, how is this going to change care? How is this going to affect patient needs, preferences, and values? We have to focus on effectiveness and not efficacy. How will it work in the real world? with appropriate patients and subpopulations, and also characterize the degree of uncertainty in general, and also how sensitive is this study or these results to the setting in which it was done. If it was done in Baltimore at a community level, will that translate to Philadelphia? Will it translate to Chicago? Will it translate to Albuquerque? Maybe, maybe not, but we should think about those things. So, to make patient-centered outcomes research more useful, this is what's fundamental. A lot of times my colleagues will say, oh, well, we have a patient advisory board. That's not even close. And Carolyn's going to go into this a lot more in a few minutes. But to have, what you really need is active, meaningful engagement by patients in the community groups that serve them in all stages of the research, prior to you even asking the question. So for those of us who are clinicians and investigators, we have to listen and make sure that the questions are the right questions, that the study objectives are including the objectives that are important to the patient. And we have to work with the patient. Obviously, the patients are not the experts in the clinical epidemiology, health services research techniques, and things like that. But when it comes to interpretation of the results, how do you communicate those effectively to the people who need to know them? So let me give you a couple examples and I'll end. Life is full of calculated risks. This is not me. I'm scared of heights, okay? There are occupational risks. There are avoidable risks. And there are unexpected risks. In medicine, most of our studies talk about relative risk reduction. That's really not what patients or even doctors or policymakers should be interested in. We don't care that this complication rate that went down 20%. The patient wants to know 20% of what? What was my chance of having a complication to begin with, and how much less will it be here, and what side effects do I get? So absolute rates are what we want to focus on. A patient-centered perspective will force that to occur. Then there's communication. This is a little dated, but it's still, you could substitute email here. Hillary's emails. The Arthur Anderson partner was on his phone when he said, ship the Enron document to the feds, but his secretary heard, rip the Enron document to shreds. It was just a case of bad cellular. A lot of times, what we think we're saying as physicians or nurses are not translatable or understandable to our patients and to the people who care for them. And we spend a lot of time developing patient education information and stuff, most of which no patient reads, and if they read, they couldn't understand. I have grandchildren now, and it doesn't matter what I think how the best way to, by the way, the grandchildren make you realize that the only reason you have children is to get grandchildren. Children are the intermediate byproduct that you really don't care much about. Because grandparents and grandchildren get along so well because we share a common enemy. That's the key thing you learn. But my grandkids communicate very differently. And if you have me try to come up with, let alone for my kids and my sons-in-laws and daughter-in-laws, but for my grandkids with a message, it will not be right. They need to be involved in framing that message and in figuring out what the right networks and channels of communication are to disseminate this. So as Paul Newman said, what we've got is a failure to communicate. Also, everybody is not at the same stage of readiness and understanding. We have to work with the people in the community and our patients to find out where are they. Have they thought about the problem yet? If not, we have to focus on getting them to understand the problem. If they thought about the problem but haven't yet effectively dealt with it, we have to help them start. And if they're trying, we have to help them keep going. So one message doesn't fit all. This is a sign that I saw in Vancouver about 2 years ago at a meeting. Attention dog guardians, pick up after your dogs, thank you. The dogs, you need a different message. Grr, bark, woof, good dog. The message has to be targeted to who we're looking at. So I would say that I think the way to think about this is a real step forward, but it's far more fundamental than just having a patient advisory board sign off on what we're doing. It means doctors and patients and nurses and investigators have to start talking to one another and listening to one another and making sure our research is meeting all of our needs instead of otherwise. Because as Einstein said, in the midst of every challenge lies opportunity. Thanks.
Thank you very much, Dr. Schwartz, and thank you for maintaining a sense of humor with the technical challenges. Do you have any questions for Dr. Schwartz? Going back to Dr. Jackson.
Sandy, wonderful presentation. I'm trying to figure out the common enemy piece.
You have a couple years to wait, Eric.
The question I have is about when you're trying to construct a learning healthcare system and you're thinking about clinician engagement in discovery. Clearly, we're here to think about patient-centered activities, but also one of the challenges is actually getting clinicians to actually want to engage in the discovery process. Could you just share a few thoughts about that?
Well, I think this is an issue that actually the further you get away from an academic medical center, the less of a problem it is. Because I think people in real practice who take care of patients full-time are very sensitive to the limitations of the information that the research community often produces and its applicability to their patients. But I think most of us, and this is, again, more of a problem for physicians and nurses, but it's still a problem. We haven't been adequately trained, and we've been socialized by a system that has sort of moved us to a medicalization model as opposed to a model that is more of a partnership model. And so I think a lot of it is, I went to college in the 60s, president of my school, closed down the university 3 times in 2 years. It was a very successful 2-year period of time from an academic perspective. But we used to say what we need to do is raise people's consciousness. And I think the two things is, one, make us realize that this is important and why it's important, because it leads to better adherence by patients. It leads to better outcomes by patients. It leads to happier patients, which means happier doctors and nurses. As Tabassum said, nobody wants somebody readmitted to the hospital. We want to see our patients do well. We spend years training. We spend many hours each week. We don't go to sleep. We worry at night about the patient we saw and isn't doing well. But how do we do that? We're going to have to. One of my other favorite stories is about a guy who wins the Nobel Prize, and he goes around and gives the same talk every night for weeks, and he's getting paid like $10,000 a night to give a talk. And he has a chauffeur who takes him from place to place. And it's really getting stale because he's bored giving the same talk every night. That's not what he won the Nobel Prize for. He won the Nobel Prize for doing something creative. And so one day his chauffeur says to him, it's getting boring and you're not even doing a good job. I could do a better job than you. So the guy says, okay, tonight I'll wear your uniform. You put on my suit. You give the talk. So the chauffeur gives a talk and gives a great talk. And he's just about to sit down and somebody like you asks a question like you just did. And the chauffeur stopped for a second and stroked his chin and said, that question's so easy, I'll let my chauffeur answer it. So I think I'll let Carolyn answer this.